And it's a great pleasure to introduce another colleague and friend who has been working in this particular area, and I think doing excellent work in this area of immune activation, and that's Peter Hunt, who is an associate professor of medicine at the University of California in San Francisco, and I think is a much invited speaker at these events. So I'm looking forward to your talk. Peter, the floor is yours.
Thanks so much, Peter, and to the organizers for inviting me. And I'll talk about the relationship between immune activation and clinical events during treated disease. And I'm going to start, I think, being cued by Peter to address why this is relevant in the modern treatment era. And we've heard that this morning from the START trial that we can dramatically reduce clinical events by just starting ART earlier in the course of disease. And are we truly out of the woods with early ART? And so this is a recent study of showing life expectancy of your average 20-year-old living with HIV in North America. Right after initiating antiretroviral therapy. And as you can see, over the past decade or so, life expectancy has been increasing steadily with modern regimens that are easier to take with fewer toxicities. But you'll notice that there still really is this big difference in life expectancy by about 20 years in patients who waited to start ART less than 350 and those who started at higher CD4 counts. And so these are more observational data sort of suggesting that there is this impact of delaying ART. And this is important to recognize in that the majority of people around the world, we're going to make a huge effort to get everyone diagnosed and everyone on treatment, but we still have millions of people around the world who have started ART at low CD4 counts. And there's still this 20-year gap in life expectancy that I think we're going to be needing to address for a long time to come. The other point I'd like to make about this study and others modern cohort studies that are estimating life expectancy is that they may overestimate life expectancy in people living with HIV. For one, at least this particular study excludes patients who are out of care, whereas the estimates that we compare to in the general population usually include all people, regardless of whether they see the doctor or not. And then an important issue is the survivorship bias. So most of the older patients in our clinics now who are informing the upper end of the life expectancy estimates are a unique group of people. They generally survived the pre-ART era. So there may be something very special about them that protected them prior to ART. And as time goes on, we may actually see the life expectancy decline because we're no longer enriching for survivors. So something to think about. And it's likely that these estimates were overestimates. As when we look at individual morbidities, many of these are increased in treated HIV infection. I've just given you a list here, but cardiovascular disease, non-AIDS cancer, osteoporosis, liver, kidney disease, COPD, type 2 diabetes, cognitive decline, and frailty, a syndrome of multimorbidity that we typically only see in elderly individuals. We do see in younger people with HIV, particularly those who have been infected for a long time before starting therapy. And so this is superimposed on an aging HIV epidemic, and this is not just a North American problem. This is a global problem, and these are data from a couple of years ago in the New England Journal of Medicine, just plotting the prevalence of HIV among people over the age of 50 in the entire population of these countries in sub-Saharan Africa, and Botswana with an over 15% prevalence of HIV in the over 50 age group for the entire country. And as time goes on, it's projected that we're going to see higher and higher prevalence of HIV. So if HIV does, in the older age group, so if HIV does increase the risk of these morbidities, we're likely to see a lot more to come. The global burden of age-associated disease is likely to be really large. And so why is this happening? We have focused on persistent inflammation as a potential driver, as Julia has told us about all those potential drivers of the inflammatory state. And we think these relationships are independent of lifestyle factors like smoking and diet and injection drug use that may also increase the risk of morbidity, and also independent of ART toxicities. And Julia showed you data from this study, or a study like this earlier, showing that T-cell activation, fails to completely normalize despite viral suppression, and soluble markers of inflammation. These are data from the Insight network, also remain abnormal despite years of viral suppression. These are data from the placebo, from the continued viral suppression arm of the SMART study, and as she mentioned, the cumulative effect of the inflammatory state on the lymphoid tissues, fibrosis persists. And so the light blue staining here is collagen in an HIV-infected individual. And this fails to reverse with antiretroviral therapy and may, as she says, impair CD4 recovery and perhaps also functional immune responses. So what are the clinical consequences of all this during suppressive therapy? And one of my favorite slides on this is from the Insight network, and they combined the control arms of 3 different large randomized controlled trials, the SMART study, the Esprit and CILCAT studies. Those are the IL-2 trials. So they're just looking at the virally suppressed arms, and several thousand patients contributing to this, and followed them for up to a decade. And a single measurement of IL-6 strongly predicts a subsequent progression to a serious non-AIDS event or death. And if you look at this, the curves are continuing to separate over time. It's not just an initial increase here and then a flat line. These curves are continuing to separate with about a 20% risk of a serious event in people in the top quartile of IL-6 compared to about a 5% risk after a decade. And that's a huge effect. And it's a much stronger effect than we see in elderly HIV uninfected individuals where IL-6 also predicts increased mortality, just not to this degree. And the fact that these curves continue to separate over time suggests to many of us that there's likely to be an inflammatory set point within individuals that's relatively stable over time. Some people have very low levels of inflammation and are probably going to do very well. And there are probably some people with high levels of IL-6 and other immune activation markers that are likely at higher risk for disease. And these populations continue to separate over time. We see similar things with IL-6, with D-dimer, rather. And if you look in the tissues, you can also see evidence of inflammation. So these are data from Steve Grinspoon's group, and he, using an FDG PET CT imaging modality, was able to show that in HIV-infected individuals, you have really high amounts of metabolic activity in the aortic plaques of individuals. So right where atherosclerosis is occurring, you see a lot of metabolic activity, which correlates very strongly with monocyte activation in the peripheral blood. And so there's this sense that these systemic markers of immune activation that we're measuring are actually also associated with inflammation in the tissues of interest, in this case vascular disease. And this is just a laundry list. You can download the slides from the website to look up the references and stuff. But just to give you an idea that the inflammatory markers or immune activation markers have now been shown to predict or at least be associated with many chronic diseases of interest in treated HIV infection. I've mentioned mortality, cardiovascular disease, cancer, non-AIDS cancer, venous thromboembolism, type 2 diabetes, COPD, bacterial pneumonia, cognitive dysfunction, depression, mental health may also be, the depression may be an inflammatory disease, not just related to social issues, and frailty as well. So all these have been related to the inflammatory state. and it speaks to the impact of immune activation on multiple organ systems. And so which immunologic pathways should we target? We can perhaps get an inkling from some of our observational studies that predict events. And this is from our own group's work from the SOCA study, the study of the ocular complications of AIDS. This was a very advanced cohort of patients with a median nadir CD4 count of 30. So half of the people had a lower CD4 count than 30 prior to ART initiation. And we only took patients who had achieved and maintained viral suppression. We selected people who subsequently died and then matched them to people by duration of viral suppression to those who remained alive, matching on nadir CD4 count, age, and gender. And wanted to see whether these various immunologic markers predicted disease. And what you can see is that evidence of gut epithelial barrier dysfunction, these are two specific markers of that, intestinal fatty acid binding protein here, and then zonulin, in which low levels we think reflects increased gut epithelial barrier function in HIV. Both of these were strongly predictive of mortality in this cohort. And if you look at several other immunologic pathways, the IDO pathway, monocyte activation, or myeloid activation, and inflammatory pathways, all of these strongly predictive of mortality with quite high odds ratios. For IL-6, there was a 70-fold increased risk of death in those in the top quartile compared to the lowest quartile. And that's just an astonishingly strong association, and I think really reinforces to us that the inflammatory state is likely to be a critical mediator of disease in these individuals. But then when you look down here at the bottom of the slide, these markers of immune activation, Julia showed Janice Georgi's seminal work on this back in the pre-ART era, where it appeared to predict clinical progression very strongly. It's much less strong a predictor of clinical events in this setting than these innate immune activation markers here. And markers, traditional markers of T-cell senescence that we see in aging HIV uninfected individuals were not at all predictive of clinical events. And in fact, higher levels of the classic senescence marker, 28 negative, 57 positive CD8s seem to be protective in this case. And I think suggests that there may be very unique CD8 T-cell effects of HIV that are very distinct from those of aging. And so what do we make from all this? Can we say that, okay, high IL-6 is so strongly predictive of mortality, therefore we should target IL-6 directly, or should we pick some other marker? And I just wanted to make the point here that the strength of a biomarker association may depend, at least in part, based on its proximity to the end organ disease of interest. And what do I mean by that? Well, let's take a marker of gut epithelial barrier dysfunction like IFAB that predicted mortality, but maybe not as strongly as, say, D-dimer or IL-6. And let's say that it does, in fact, predict cardiovascular death. In order for it to do that, it may have effects, it may be modified first by an individual's gut microbiome, may be further modified by their Th17 or Th22 response to contain microbial products. It may be further modified by their neutrophil function, hepatic clearance, lymph node clearance, the extent of macrophage activation, the extent of atherosclerosis for any given degree of macrophage activation, the extent to which those plaques are likely to rupture, the extent of tissue factor expression and coagulation, all these things. There are multiple steps, and at each step along the way, there may be differences between individuals that may introduce a lot of variability. And so the association between IFAB and, say, mortality or myocardial infarction may be a little bit weaker than, say, a marker like D-dimer, which is very closely related to the the end result. And it's also true that there may be certain final common pathway biomarkers that may be the final common pathway of many clinical events. And so many root causes of the inflammatory state might converge on some of these biomarkers. And so I think we need to think in systems as we integrate all this information and try and decide where best to intervene. Another point along these lines is that the biomarkers that predict disease likely depend on the clinical setting. And so in these two cohort studies that I've shown here, the SOCA study and also Alan Tenorio's newer ACTG study that was published in the same issue of JID, both of these studies show that IL-6 was the strongest predictor of mortality, and T-cell activation among these 5 was the weakest. And I've ordered these in terms of the ranking about how strong it was. But if you look in Uganda or other international settings that include resource-limited settings, you see a different order of the biomarkers that predict disease. And markers of adaptive immune defects, including T-cell activation, predict mortality there, even in the setting of viral suppression. And innate pathways that confer adaptive immune defects, like the IDO pathway, are also tend to be strongly predictive there, and more so than some of the other pathways that predict disease in US-based cohorts. And so why is this? And one possibility could be that in US-based cohorts, it's primarily non-infectious causes of death that we're seeing, cardiovascular, cancer. And in resource-limited settings, a lot of the deaths are still infectious complications where the adaptive immune system may be more important. And so perhaps we need to think about that when interpreting our observational studies. And we need to think about these biomarkers in a system with a systems type mindset. And we need to think about the mechanisms that Julia outlined by which HIV may activate the innate immune system, leading to multiple downstream parallel pathways. The adaptive immune defects down here are closely related to infections and malignancies. Perhaps that's why we're seeing the strength of those associations in resource-limited settings. But really, where do we want to intervene? We probably do want to intervene more proximally, either in the root causes of the innate immune activation or in the very early stages of innate immune activation that give rise to multiple downstream pathways. So with that, I'll close and just summarize that despite optimal ART, HIV increases mortality and many age-associated morbidities. Immune activation and inflammation persist despite ART and predict these morbidity and mortality over the long term. And there may be this so-called immune activation set point within individuals that may predict this risk. Adaptive immune defects may be more important in resource-limited settings where infectious complications are prevalent. And biomarkers that predict disease most strongly are not necessarily the best interventional targets. We need to think about the root causes of the inflammatory state, I think, to select our interventions. And we need also to integrate biomarker studies with a pathway approach to inform interventional targets. So with that, I'll just close by acknowledging many of my collaborators that contributed to some of this work, and then we'll take questions.